Okay, so come have a seat. Carry on. You say there's a lady? Okay, but she looked quite stable. Yeah, okay. No. All right, so like I was saying, today we're going to talk about the ultrasound and how we use it to diagnose an EFAS. I mean, how to diagnose a pneumothorax and EFAS, not how to diagnose an EFAS. Sorry. So, like I say, traditionally, pneumothorax was seen as something that you either diagnose clinically. That means you see a sucking wound, you feel surgical emphysema, things like that. And otherwise it was X-ray, and that was it. But actually, if you become very good at it on ultrasound, you have like about a 95% chance of picking up pneumothorax on ultrasound rather. And in fact, it's much better at picking up small pneumos that appear just at the top, the apex of the lung. All right. So that's what we're going to concentrate on today. So the pleural window. Okay. So it's not displaying too well over there, but I hope you can just see it a little bit. So the way that we place the probe, essentially it's with the pointer towards the head, right, or the indicator towards the head. And we place it on the intercostal rib spaces, okay? But there is a little video just now that shows it to you a little bit better, okay? So there's quite a bit here. You can read through it when you have a chance. Now, the question is, what are we going to see? Now, even before we get to what we're going to see, there are a lot of problems that people sometimes, or mistakes people make when they first try. When we're looking at the lung, we're not trying to look through the whole lung. We're just trying to look through about 3 to 4 centimeters of it. That's about it, right? So the most important thing when you do your lung ultrasound, check your depth. Make sure your depth is not too high. Because if, for instance, you look at this diagram, this is what we're going to see, right? So our probe is here. We've got a little bit of skin. We've got soft tissue. We're trying to get in between two ribs, all right? The ribs cast a shadow. So in other words, we can't see anything behind there. And then we see lung tissue behind there, all right? Now, in ultrasound, there's a lot of lines, okay? There's a lot of lines. When you really get into, it's, like A lines, B lines, Z lines, I lines, H lines, every letter has something associated with it, all right? But the one that I want you guys to take note of is something here that we call A lines, all right? So just for a second, we're going to concentrate on the physics of ultrasound. So if you guys remember back to the first lecture, we said that when ultrasound beams hit something, ultrasound is waiting for those beams to be shot back to it, right? To bounce basically and go back. Right? So bone bounces back everything. All right. So everything that hits this bone goes back to the probe. That's why you don't see anything beyond that. Right? Anything that's fluid, semi-solid, depending on its density, will bounce back, bounce back, bounce back, bounce back at different speeds and at different times. So that's how it creates an image throughout over there. Lung or air absorbs everything. So in other words, every ultrasound beam that goes here carries on through. Nothing gets bounced back to the machine. So technically, the machine shouldn't be able to see anything in the lung. Right? So with lung ultrasound, and that's why initially ultrasound was actually thought to not be of any use in the lungs. Right? And then about 34 years ago, these guys started using it in the ICU, and they realized there are ways to actually pick up things. Even though technically you're not seeing anything, you're seeing something that we call artifacts. Right? And artifacts are actually what we look for. Now, what happens is when your probe is here, this is your pleura. Right? So you have two sides to the pleura. You have your visceral pleura, and you have your parietal pleura on that side. Right? Now, these are semi-solid to solid structures. Okay. So what happens is the ultrasound beam hits this and goes back. Okay. But it doesn't absorb everything. So the rest of it that's going through, whatever is going through over here, those ultrasound beams, because they're not getting physically sent back, it kind of confuses the machine. The machine knows that there should be something behind that. So what it does, in order to satisfy itself, it makes replicas of the pleural line, okay, which are called A lines, okay. So when you see A lines, it means that there's normal lung tissue. In other words, there's normal air that's in those lungs. The lung is absorbing everything. So the only thing the machine can see is the pleura, and it replicates the pleura a few times. In fact, this is not the best view. You normally get about 7 or 8 of these in a normal field. Okay, so you just see these lines streaking across. It's a good way to see that the lung is normal. Okay, Now, specifically, when we're looking to make sure that we are going to see the right thing, we look for something called the bat wing sign, all right? So going on our diagram before, we have skin, soft tissue, two ribs, pleura, rib shadows, and here we see all the A lines, okay? Can you see all of them replicated over there? So that's how we know we're in the right place, okay? And they call it the bat wing sign because that's what it looks like, a bat wing, okay? So does everybody understand that? Anybody's got any questions about how that works so far? This is not in-depth lung ultrasound. This is basic lung ultrasound. Okay, so, but I know it's still a bit technical because guys haven't really done this before. The other thing to note is that how shallow the view is. Okay, so you're not looking for a big area. You're looking for a small area. You're looking for one piece of the pleura so that you can actually assess it. Okay, now, all right, we'll get onto that now. Let me just, so we got a little video here. Just have a look at it and see. Yeah, come on. Sorry.
Our next thing is going to be the intercostal view, looking for the presence or absence of pneumothorax. We're looking at the mid-clavicular line in the second intercostal space, right where you would needle decompress, and we're looking for the presence or absence of pneumothorax. Now remember, we are looking for large pneumothoraces that would impact our care in the trauma bay and need immediate decompression or treatment, not necessarily small pneumothoraces that can be evaluated further. With ultrasound, we're evaluating for the presence or absence of pneumothorax under the probe, meaning we are looking in a single spot for the presence or absence of pneumothorax, not excluding it throughout the entire thorax. What we want to do is identify our key landmarks. We're going to identify two ribs, and we're going to look at a pleural line in between to get a view of what's going on with the lung. However, there is going to be a large amount of air artifact, which is the hallmark of lung ultrasound, and what we're paying attention to is the pleural line between the two ribs. You want to identify two ribs so you can have anchoring landmarks to identify the pleural line in between. We're looking for our two ribs here, and we're looking for that pleural line in between the two ribs. You want to center on the pleural line, not on the. And what we're looking for is what's called lung sliding or pleural sliding. And as the person is breathing, you can see that pleural line sliding back and forth with a shivering or sliding effect. And this is what we're looking at. In the far field, we're looking for the presence or absence of B lines, but however, we are focusing on the intercostal space at the pleural line there, looking for sliding, telling us that there is normal aerated lung, or no sliding, telling us the presence of a pneumothorax. Here's another view with a linear probe showing the two ribs and the pleural line sliding back and forth at a little higher resolution. Here's another view where we're seeing lung sliding with a curvilinear probe. And what we want to do is turn off post-processing, meaning turning off compound imaging or multi-beam and harmonic imaging. And you can see that the pleural sliding is much clearer when these post-processing things are turned off. They try to suppress artifact and may reduce sliding. If you are unsure if you see lung sliding with these items on, be sure to turn off both harmonic and multi-beam or compound imaging to highlight sliding to ensure that there is lung sliding or no lung sliding. The other option to evaluate for lung sliding is the use of end-mode. And what happens is you evaluate the pleural line, you drop your end-mode spike through it, and you're looking at the end-mode tracing. And this allows you a better view of presence or absence of lung sliding. So if you see lung sliding clearly on B mode or 2D imaging, you don't have to do M mode. However, if you're unsure, that's where M mode will come in handy to help you differentiate. You drop the M mode spike through the pleura, and what happens is everything along that M mode spike is plotted over time. So you see that single line plotted over time on the x-axis. Everything along the M mode spike will be plotted over time, so the chest wall, which is not moving, appears in straight lines as there's very little to no movement. Whereas the lung and the pleural line, which has a lot of movement and artifacts, shows this textured appearance over time. This is called the seashore sign, as it looks like there is beach and water. So along this area, you see the pleural line there, you see the chest wall and the lung. Now, the chest wall shows you no movement, so there's a linear pattern, whereas the lung shows you movement, causing that speckled appearance. Here you have another example of lung sliding. And what we can see here is a pleural line. We see the chest wall and the lung, and no movement in the chest wall versus movement in the lung. So once again, we're going to get our view of the pleural line anchored by two ribs on either side. We're going to drop our M mode spike, and we're going to get our M mode tracing showing lung sliding or the seashore sign. Here we have our two ribs anchoring the view and our pleural line between them. And you see that that pleural line is not shivering or sliding back and forth. This is a patient with a pneumothorax with no sliding. Here you can see another example. Two ribs, pleural line in between with a lot of refurb artifact from free air within the hemithorax. And we have no sliding at the pleural line, and we have a pneumothorax. There's another example. Every time the person tries to breathe, you see the chest wall move slightly. However, you do not see the pleural line slide. This patient also has a pneumothorax. If we were to drop the M mode spike through that, you see the linear pattern of no movement in the chest wall, pleural line, and a matched view of no movement below the pleural line, showing you the absence of lung sliding and a pneumothorax, also referred to as a stretch theater site. Here's another example of pneumothorax. You can see the pleural line. There is a little blip where the chest wall is moving, causing movement throughout the field and not just in the lung. Here you can differentiate between the two, with lung sliding present on the left of your screen and pneumothorax present on the right. You can see the textured pattern of movement on the left below the pleural line versus on the right below the hyperchoric pleural line. There is no movement either above or below it. This is a finding that's called a lung point, where you have an area of pneumothorax, and as a patient inspires, the lung inflates, and you see some area of the lung slide into view. So you see lungs sliding appear and disappear. This is at the very edge of the pneumothorax, where the area of the lung is moving into view. This tells you that there is a
little bit of depth about how it is, but the most important thing to take away from there is what you call it, the sliding versus no sliding. Right? So if you can see pleural sliding, it's quite easy after a while. Right? So what they describe it as.
Our next view is going to be the intercostal view.
Sorry about that. So basically, what happens is that now we're going to take a look now at some examples of it. Right? So this is a normal lung. Okay. So we've just got a little gif of that going. Right? The one thing I want you to notice is this little shimmering pattern. Can you see that? Can you see those little almost like spikes that come out? Now those are called comet tails, all right? The other way they describe this is ants walking on a log. So if you come in really close and you have a look here, it looks like little black dots also just moving up and down, right? So basically what we're saying visceral pleura and parietal pleura sliding over one another as the patient takes a breath. Right? Now this patient gets stabbed, all right, shot, whatever it may be, air starts to collect between the two of them. So nothing happens. All right, there's movement here, but not necessarily movement there, okay, because the lung is no longer functional. And then if we compare that to a pneumothorax, here we've got again, as they were saying, there is soft tissue movement. But have a look here. All right, so we've got rib, and we've got pleural line. But notice you don't have those little shimmers like what you have over here. And if you look at the two pleura, it doesn't look like anything sliding one over the other. Okay, so that's how you kind of figure it out. Now, in some patients, it's quite easy. You know, it's a very obvious thing. You can make it out, but it comes with practice as well. You know, you can't just put a probe once, you'll know immediately, but you've got to try. And in some patients, it can be difficult because the chest movement is so excessive. You don't know whether this is pleura moving as well or whether it's lung moving. That's where the M mode comes inside. We're going to talk about M mode a little bit more just now. Right? So like I say, absent lung sliding, no comet tails. So just to make it clearer what a comet tail is. So you've got your rib, pleural line, and then this is a comet tail. Right? Now it's also known as a B line. Right? So the first one that goes horizontally is called an A line, and this one here that shoots down is called a B line. So what happens with the B line or comet tail? It moves, goes with that part of the pleura. Okay, so just remember that. And then again, if you look again where we've got this pneumothorax, you'll notice there's no B lines whatsoever. Go back to this one, even though they're not as prominent, but you can still see them. Okay, so in other words, if you use your ultrasound, you can determine if there's a pneumothorax within 20 seconds. Yeah. And you know whether you need to actually put in an IC drain or not. Now, in saying that, do we put in IC drains for every single pneumothorax? Not really. If it's a tiny pneumothorax, we don't. Okay, we do sit and watch it. So what you need to worry about is, number one, is there a pneumothorax? And number two, how big it is. Okay, so we're going to get onto that now. I just want to share a little bit more about M mode, because M mode is one of the more common things that you need to know.
In addition to using E mode for lung sliding, also use M mode with the lung sliding. So the indicator is going to be up towards the patient's head once again, and the same view as you have for your V mode scan, you have it for that lung sliding there. So you see lung sliding, you put the M mode cursor across that pleura, start the M mode. lung sliding. You can see what they call the diet or standing.
Can you see that?
That's normal. Pneumothorax, lung sliding, and the barcode sign or
Now our machine does have M mode, right? We've got 3 modes. We've got the color flow Doppler.
Which one? I was working with two
Pulse
nurses.
wave,
Which
but
one?
M mode. M mode is easy.
So
That's quite an easy one. So when you put on M mode, the most important thing is that if this is your view that you're going to see, they all come with a little indicator, either a little line or a cross or a dot that's bigger than the others. That must basically be across your pleural, what it is. Yeah, okay. So if you have a normal lung, that's when you see this sandy beach sign. Okay. So in other words, you see waves and you see what looks like a sandy beach. That's all M mode does. M mode is converting the movement of whatever tissue you are looking at into a graphical representation. So in other words, because there's movement of the lung, and if there's a pneumothorax, because there's no movement of the lung, it now changes into more of what looks like, if you can imagine, just waves. Right. We call it the stratospheric sign, barcode sign, whatever you want to call it. And here we see another example of it. Right? Seashell sign, so sky, ocean, beach. Even if you just say waves and beach, whatever it is, it depends on the size of the patient as well. And here you have a barcode or stratospheric sign. Now, when you look at these, the one thing that sometimes can confuse you, because can you see here, this is where the patient is breathing, all right, or trying to breathe. So if you have a patient who's breathing quite fast, then sometimes these little batches can come together much closer, and it can be a bit difficult. It's not common, but it does happen, in which case you should ask for senior help, ask somebody who's got more experience and say, listen, am I seeing what I'm really supposed to be seeing? Okay. Now, the other thing that he was talking about is a J point. Now, a J point is a fancy way of saying, where does the pneumothorax end? All right. So just wanted to show you one here. So this is what they call a J point or a lung point. Right? So what we see here, we see pleura that's not moving. Can you see that little section over there? Basically, there's no movement there. And then you compare it to this side, and you can see movement of that pleura over there. Right. So what it tells us is that up to that point, now this may be anywhere. This could be the 3rd intercostal space, 4th, 5th, 6th, 7th. Ideally, you can follow the whole thing down. But eventually, you'll reach a point where you see there's normal lung and abnormal lung. And that can give you a good idea as to whether this patient needs an IC drain. Now, of course, it depends on the context as well. You have a massive polytrauma patient, and you see that there is a pneumothorax. I wouldn't now go step by step. Rather put an IC drain and be safe, because this patient can complicate very quickly. You have somebody with a little stab wound who's stable. You see you've just got a little J point at the top. Send them for X-ray, see if you can see how big it is. You don't have to rush to put an IC drain every time you see a pneumothorax. Big sucking wound, and you're practicing, of course, put an IC drain. Okay. So the one nice thing about J points, and when you do find them, is that it actually gives you both of the signs together. All right. So here we have the sandy beach sign. And here we have the barcode sign right next to one another, because on this side, there's normal motion, and on this side, there's no motion. Simple, isn't it? So it's not difficult to diagnose a pneumothorax on ultrasound. And it can save you a lot of time, especially with your polytrauma patients. Remember, up to now, we're just talking about the ER. So you've done your liver, you've done your spleen, you've done your bladder, and now you're going to the chest to see if there's anything going on there. The next thing that we're going to look at is the basic pericardial view. Okay, so this is something, it's nice to just go back and revise and have a look. And when you have patients, just go and just check. There's no harm in checking, just to see what's going on and get used to what's normal. Because then when you see abnormal, it's much easier. Okay, any questions? Anything you guys want to know? It's very basic ultrasound, right? And it's a simple, easy process to do. You don't have to use M mode every time. You can just have a look at the lung and decide whether or not. So the only way to get used to it is to actually do ultrasounds, all right? Take that machine out of the corner. It doesn't only work on that plug in the corner, it works on all the plugs. Don't worry, I've tried it. So try it, take it out, put it there, put it next to the patient. Patient is complaining of coughing, never mind, do a lung ultrasound for them, just have a look. Because you might start picking up things that you haven't picked up before. You may not know the diagnosis, but at least you can see, something's normal, something abnormal. And if you have a stabbed chest, definitely try and do it. Okay, or an injury to the chest, even blunt trauma to the chest, query fractured ribs can also give you all of this. Okay, all right. So if there's no more questions, then I think we'll end there for today. Tomorrow we'll have the ECG presentation that we're going to have on Monday. All right. So I'll just put out another invite for that. Okay. Have you guys been getting your CPD points? Been coming? No? But some have been getting it. I think unless she's getting through it. But I'll ask you. If yours doesn't come, then just let me know. Okay, guys on Zoom, I don't know if you'll have any questions or anything you want to know. Or if there's anything that's still confusing you. Oh, sorry, I see somebody put a chat. Okay, nope, thanks, okay. And yeah, all right, guys. So thanks a lot. And then I'll post all of this, including the, the actual video itself onto, onto the, I'll post it onto the group as well. Okay, no problem. All right, let's get back to work and you guys enjoy your day. Okay, bye.